Hello, everyone. It's great to see you. Thank you so much for your patience. My name is Deborah Yashar. I'm the director of the Princeton Institute for International and Regional Studies, and I want to welcome you to our Global Existential Challenges seminar. Today, in particular, we'll be talking about public health and well-being, learning from the past, and preparing for the future. The topic could obviously not be more salient or more important, and this is one of those topics for this seminar series where I know I don't need to provide a particular justification or introduction other than to say just a few things here, which is that oftentimes we have conversations, we tend to hear words like, or phrases like, health is a human right. And even if you agree with that, and I'm one of those people who does, the question is, if it's a human right, how does one actually get there? How does one deliver it? How does one protect it? How does one move forward? And this is where, in many ways, conversations about public health are at the forefront. But they're also a source of great political debate, and they're central to our ability to provide healthcare and services to domestic and global populations. So you need only think about access to public services and drugs, research and development, public regulations and norms, health outcomes and their inequalities, both domestically and globally, and so much more. Obviously, COVID shined a particular spotlight on these questions. So even if you had not thought about public health, had not thought about health as a human right, COVID in many ways reminded us in the most central and immediate of ways of how important health is for us as individuals, but also for us as communities. Raised questions about infectious diseases, but also non-infectious dynamics, and putting at the front questions of health and well-being. So this panel is jumping in. I could say so much more, but this panel is jumping into this core set of questions, and they're going to help us to think about not only their work, and we have 4 amazing scholars who are going to share their own work and insights, but they're going to help us to think about this dynamic in light of what we can learn from the past and how we can prepare for the future. So let me just introduce them briefly, and please excuse me, I'm not going to give long bios because this is a short panel with 4 incredible people. But we're going to start off with Angela Creager, the Thomas M. Siebel Professor in the History of Science. She's also chair of the History Department, and interestingly is also a biochemist, which I think is interesting in particular, and she'll speak about chemical regulation, testing gaps in private data. She'll be followed by Sanyu Mojolo, who is a professor of sociology and public affairs, the Maurice P. Doring Professor of Demographic Studies, and also the director of the Office of Population Research. And she will be speaking about the power of place in shaping health and illness, which I believe will be focused on the United States, but you've also done work in Africa. No, it's broader than that. In South Africa. Third, we will hear from Noreen Goldman, the Hughes-Rogers Professor of Demography and Public Affairs, and she will speak about reconsidering vulnerability and mitigation strategies for COVID and respiratory infections in general. And then finally, Jess Metcalf, Associate Professor in Ecology, Evolutionary Biology, and Public Affairs, but in fact a demographer in terms of initial training, will be speaking about emergent pathogens and landscapes of immunity, and the core question being, what would pathogen X look like? So we have a full panel, a diverse group of people, a multidisciplinary set of conversations, and I'm about to turn it over to them, but just a few housekeeping points. Each speaker will have about 12 minutes to speak about these really critical questions. If you see me going like this, that only means, I'm signaling to them 2 minutes before their time is up. And we are taping this. So again, as you're listening, just be mindful that there is actually a video that will be in place as well. And with that, please give them a warm welcome. Thank you so much.
So I'm really delighted to have a chance to speak with you a little bit about my current work on chemicals regulation. And what I want to do is to just say a little bit about how the regulatory system that we have for chemicals has generated gaps in knowledge and health and environmental vulnerabilities to toxicants. So industrial chemicals pervade modern societies and markets to such a degree that the chemical industry today functions as a kind of a basic driver of the economy. It's been dubbed the industry's industry. And what I mean by that is that basically every sector of the economy, from agriculture to armaments, uses chemicals, especially commercial chemicals, in whatever they make or manufacture and sell. Chemicals' impacts on human health and the environment are extensive, complicated, and far from completely understood. Now, the possible hazards of the massive production, use, and disposal of synthetic chemicals became politically important in the environmental movement of the 1960s and 70s, which resulted in a new regulatory apparatus. And what I want to do is to say a little bit about that history of chemicals regulation and why it didn't fully address the issues. So I want to start with just familiar background, although old background now, older than me. In 1962, Rachel Carson's Silent Spring focused public concern on the dangers of agents such as DDT and synthetic chemicals and industrial pollution, what she termed the so-called elixirs of death to humans and wildlife. Historians have documented how the impact of this one book drew on several other developments, such as debates over radioactive fallout from atomic weapons testing, the pollution of rivers and landscapes with noxious industrial waste, and the loss of native plants and animals due to suburbanization. Now, these debates were not only within the US, but also around the world, as epitomized by the United Nations Conference on the Human Environment held in Stockholm in 1972. So how does one figure out what chemicals are dangerous to people of the many that are on the market? And I'm going to focus here especially on carcinogens because I'm looking at a test to try to identify carcinogens. So obviously human experiments with potential carcinogens would be unethical, and epidemiological studies, if you want to do that, are lengthy and stringent, sometimes missing low-dose effects. So toxicologists have conventionally relied on testing substances in laboratory animals to assess the dangers to human health. And the standardized tests that they have developed occupy a central place in generating the evidence for regulatory decision-making. And I just want to kind of quickly say, this is not unique to the realm of chemicals regulation. In the kind of, especially in the 20th century, but in the modern period more generally, many different decision-making bodies rely on some sort of standardized test or another as inputs for governance, whether it's nuclear testing, education, medical diagnostics. I mean, the role of testing and the knowledge from testing in regulatory decision-making is, and also just ordinary decision-making, think about college admissions, right, is really pervasive. But it also means that the goodness of the regulatory decisions that you have relies on how good the tests are that are the input for that decision-making. And I've just cited one classic article on the sociology of testing. So out of a tradition of using animals for toxicity testing, after World War II, government scientists developed a standardized test for carcinogenicity using two rodents, rats and mice, and long-term exposures at half the maximally tolerated dose. Animals, 100 animals or so, would be subjected to this. Surviving the 2-year course, were sacrificed and examined for the appearance of tumors. And if they had already died, they were obviously autopsied for those tumors as well. These are very costly experiments. Already in the 1970s, it could cost $2 to $3 million to do an experiment. And the results were not beyond question. Actually, I think it's $250,000 to $300,000, pardon me. But the results were contested because of the relatively high dose at which the animals are exposed, the fact that there's differences between species. Sometimes even rats and mice don't give the same results. So then the question is, what's the result for humans? And there's also an inherent predilection for tumors in these test animals. But there really were not, and even to this day, are not such good alternatives for assessing the health effects of long-term low-dose exposure. And in the 1960s, there were thousands of new chemicals entering workplaces, foods, drugs, consumer products, and the natural environment, especially in the wake of the petrochemical revolution, which made oil a feedstock for a lot of synthetic chemicals. So animal testing was required for certain chemicals like drugs and pesticides, but generally, many chemicals were not regulated by federal statute in the US. And the National Environmental Policy Act, which was signed into law in 1970, it's best remembered because it created environmental impact reports. That law also created a Council on Environmental Quality. And under Richard Nixon, this new council was especially targeting concerns about toxic chemicals, as, of particular health and environmental worry. And this is just, they had a 1971 report that was quite influential, and they highlighted the role of biomagnification, which had earlier been seen with radioisotopes. They argued all forms of life are being potentially exposed to potentially toxic substances. The Nixon administration then introduced a bill into Congress called the Toxic Substances Control Act to try to be a stopgap for the regulation of chemicals, so that chemicals that weren't already regulated under other statutes would still have some base health and environmental regulation. That bill was hung up in Congress for 5 years. It finally passed under the administration of General Ford and was signed into act. And this legislation was especially aimed at regulating chemicals whose effects, especially cancer, birth defects, and heritable mutations, resulted from long-term and chronic exposure, especially of DNA. Traditional toxicity testing had a focus on acute effects. So if you're near something, does it make you immediately sick? But concern with this new generation of synthetic chemicals really focused on long-term effects. If you're exposed to something at low dose for 40 years, does it make you sick, and how do you know? Now, the EPA faced a lot of procedural hurdles in fulfilling its mandate, because on the one hand, although the bill talks a lot about testing, in the end, the bill does not require new tests for any new or existing chemicals. For existing chemicals, they're assumed to be new unless there is data otherwise. And for new chemicals, any data that existed had to be submitted, but that actually created a disincentive for doing testing. And in addition, and those parts of the bill were concessions made to the chemical industry, which had held up the bill for 5 years and really didn't want any mandatory testing. In addition, TSCA, as it's called, has a mandate to make public health and environmental information about toxicity of chemicals. However, there's also a mandate to protect proprietary information, which is called confidential business information. And what that meant was that companies that didn't want to release health, safety, or environmental data would simply call it confidential business information. And they could also use a generic name for the chemical, so even if there was information associated with that chemical, it couldn't be traced back to the actual substance. And so this really revealed the conflicting mandates of the EPA, that on the one hand, they're supposed to be sharing publicly information about these issues. At the same time, they protect industry data. And so the other side of testing is data. Who has access to it? How is it known? At the same time, at the international level, other countries were enacting national laws for controlling chemicals, and a European Communities Amendment was adopted. And many of these had provisions for some sort of safety assessment or notification of commercial chemicals. And the result was that countries began having different standards for what would be required of chemicals to be acceptable in a regulatory framework. And because this creates a non-tariff barrier to trade, there were concerns that it might interfere with the growth of the chemical industry as a global industry. So then there was a push initially coming from the US EPA, but then also from many countries in Europe, to get the OECD involved. The OECD, the Organization for Economic Cooperation and Development, is known mostly now for its study of economic indicators, but it was also getting involved in the 1960s and 70s in environmental issues, because they posed transboundary problems affecting more than one nation. For instance, they were absolutely instrumental in negotiating a resolution to the acid rain controversy, in which coal-burning Britain's pollution was affecting Scandinavia. Now, the chemical industry wanted the OECD to take a lead on this issue because it only represents industrialized countries. If the UN had taken a lead, it meant the non-industrialized countries would also have a say in the safety of chemicals. So it was the OECD that then was charged with coming up with international regulations around chemical safety. And they worked for years to come up with a minimum. Oh, and then also the Sixth Amendment in Europe began to suggest that there should be a minimum test data set that should be done on every new chemical. The OECD adopted this as well and spent several years specifying what this data set should include, which included various kinds of toxicity testing, not just things like physical characteristics, boiling point, et cetera. And in Europe, there was great, optimism that industry would allow the flow of specific information about chemicals alongside the global movement of chemicals and trade. However, the election of Ronald Reagan and the appointment of Ann Gorsuch as the director of the EPA meant that this was undercut by the U.S. So in the high-level meeting in which all the environmental ministers were supposed to sign on to this new pact, the EPA insisted that the language be required. So instead of saying that new chemicals will have this data submitted, the wording was that they may have this kind of information associated. So that basically undercut the possibility that international regulation would do what U.S. regulation had failed to do. So what's the outcome of all of this? It means that there's I think, an inadequate regulatory system, both at the U.S. level and in terms of the global trade. The EU has been the most active in trying to redress this. Their new chemicals law, which has the acronym REACH, now requires data on existing as well as new chemicals, and those dossiers are actually made public, which is really different than US law. However, European scholars are finding that a lot of those dossiers contain poor or old data. And it also remains to be seen how much this will actually affect things. The US then updated TSCA in response to the EU, and under President Obama, it was signed into law in 2016, but the election of Trump meant that this law was being implemented under his administration. So it's not clear that that's actually going to address the gaps in knowledge. And so many nonprofit agencies have turned to working directly with companies and trying to get certain dangerous chemicals out of their products. And this has been very innovative. At the same time, those agreements are often very fragile. They're not enforced by law. So I think environmental organizations are also trying to navigate in a world in which it's very hard to work through political representation to affect change. So, and there's more on this in a book that I published a couple years ago with a bunch of co-authors. It's called Residues. So that's it. Thank you.
Well, thanks so much for the invitation and opportunity to share my work. So I'm going to be talking about the power of place in shaping health outcomes, and I look forward to your questions and comments afterwards. So I'm first going to talk about social determinants of life and death. I'll offer a brief theoretical framework, a brief case study on some of my work in South Africa, and then offer some concluding thoughts. So I'm going to first begin with a quote from Eric Peter Ekholm's book, The Picture of Health. Individuals who enjoy good health rightly think of themselves as fortunate, but luck has little to do with the broad patterns of disease and mortality that prevail in each society. The striking variations in health conditions among countries and cultural groups reflect differences in social and physical environments. And increasingly, the forces that shape health patterns are set in motion by human activities and decisions. Indeed, in creating its way of life, each society creates its way of death. It's important, I think, to state the obvious, right? We're all going to die of something someday. As far as I'm aware, there's no pill for human immortality. But who gets sick and dies at a given time is not random in a society or population. It's unequal and it's predictable. So death is not randomly distributed across the US. As you can see, people living in states like California, Minnesota, and New York can expect to live about 81 years, while those living in states like Mississippi and West Virginia can expect to live about 74 years. A 7-year difference. This is pretty significant when you think about it. This is looking at it by US Census Tract, work by Arias and colleagues at the National Center for Health Statistics. So you can see even within state, death is not randomly distributed. And this is New Jersey. Death is not randomly distributed in New Jersey either. It has one of the highest life expectancies in the country, but even within it. So you can see Princeton, right in the middle, right? So you're ranging from 65 to 75 to 86 to 95, even within such a small state. And you can find this on NJGov if you want to pinpoint your neighborhood. So I draw on two concepts in my work to understand the role of place in shaping health outcomes, syndemics and the idea of sociospatial containment. So let me discuss these in turn. So what the disproportionate death by zip code suggests is that either one main of cause is predominant in that place or that multiple causes of death cluster in some places. And so the term syndemic is used to describe the phenomenon of clustering of two or more diseases among particular populations, where biological interactions or synergies among the diseases further exacerbate vulnerability within the population. A number of syndemics in the US include combinations of TB, asthma, sexually transmitted infection, depression, substance abuse, violence, and HIV/AIDS. And so we've been in the midst of a national syndemic, for example. So COVID-19 preyed on counties which already had co-occurring chronic disease epidemics of diabetes and heart disease. And then it amplified mental illness, homicide, and substance abuse epidemics, specifically alcohol and opioids. Right, so that's a syndemic. Okay, and so the non-random distribution of diseases and their tendency to disproportionately cluster among places and people groups is a product of what I'm calling social containment. It expresses the ultimate effects of segregation, the separation of groups on the basis of a particular characteristic like income or race, by emphasizing the idea that segregation ultimately works toward the containment or clustering together of privileges and inequalities in physical or social space for particular groups of people. So social containment then characterizes how a group creates and then maintains its status through gathering and consolidating privileges, and then working through a variety of mechanisms such as laws, policies, regulations, and inertia to exclude other groups from them. So across societies, the form of social containment might vary. So racial containment, ethnic group containment, income-based containment. You can see this with schools, for example, as examples of social containment. And these are often expressed through space. So I call this phenomenon sociospatial containment. Now, a parallel process advertently or inadvertently gathers and clusters together social ills. And this might occur for the initially expedient reasons, such as necessity to house increasing numbers of the poor, leading to relaxing housing regulations, or the need to locate certain necessary functions of a city or state, such as sewage systems, garbage dumps, and commercial facilities. So these areas will then have the cheapest housing, attracting those unable to afford more. So the concept of sacrifice zones captures this idea. This is Lenin, some work by Bullard, that certain spaces in a city or state are more likely to contain toxic waste dumps, industrial buildings, be located near high pollution highways, be built on environmentally tenuous land where buildings are more vulnerable to flooding, and so on. And so these spaces are then contained through physical and natural barriers, such as highways, bridges, railway tracks, parks that separate affluent, middle income, and poor neighborhoods. And so people in marginalized communities are then often contained in the most unhealthy places. And so the ultimate effects of social containment, as in Nancy Creager's work, are embodied, right? And they show up in ill health and premature death. And so in this way, then processes of sociospatial containment also create and then contain what I'm calling syndemic zones. This helps us understand why ill health and premature death cluster in minority or marginalized families and neighborhoods, and why health disparities persist across generations. So the same spaces that had, for example, COVID also had heart disease, also had lots of other diseases. So let me turn to just briefly to a case study in South Africa. South Africa has the most severe HIV epidemic in the world. Almost 8 million South Africans are now living HIV and AIDS, about 1 in 5, 20% of the adult population. And it also has the highest proportion of older people in sub-Saharan Africa. And so in combination, these significant demographic shifts suggest that South Africa will soon be coping with the largest number of adults transitioning to older ages with HIV. And findings from our project, HIV After 40, have highlighted the critical role of place and space in shaping the health outcomes of rural South Africans. The study is based in the Agincourt Health and Sociodemographic Surveillance Site run by the University of Witwatersrand. And this is in Mpumalanga province in northeast South Africa. So it's near Kruger National Park. So it's a former apartheid homeland area. And while much has changed, it remains burdened with a long legacy of policies of differential development, which created poor communities and weak health services. It's a low rainfall setting with limited subsistence farming and employment options. And this is no accident. So this history will be familiar to many of you. The predominant process of socio-spatial containment in South Africa was apartheid. The system of apartheid institutionalized racial, gendered, and geographic separation, which entrenched Black poverty and disenfranchisement. A series of acts between 1913 and 1975 forced the relocation of African populations into so-called Bantustans or homelands, with poor agricultural lands and limited economic infrastructure. The 1951 Bantu Authorities Act, for example, relocated 70% of the African population to 13% of the land. And men were coercively recruited to work in distant mines and farms, where many lived in all-male dormitory-style hostels. They were denied South African citizenship, and so men required an official pass to travel home. And so they'd go home once a year or every 18 months. And so this forcible separation of families shaped gendered norms and expectations of sexual partnering, both in workplaces and in apartheid homelands, as long-term partner separation enabled extramarital and concurrent to overlapping sexual relationships. So as my research group and many others have documented, this sexual economy was a driving factor of high HIV rates in South Africa. And in former apartheid homeland areas like Agincourt, even during the post-apartheid period. Similarly, relocation onto poor agricultural land changed diets and nutrition and also had consequences for chronic diseases in the post-apartheid era. And so the figure depicted here shows you the high HIV prevalence rates in our study context, Agincourt. As you can see, HIV prevalence rates are especially high among young adults. So by the early 20s, a quarter of young women, almost 10% of young men were living with HIV. By the mid to late 30s, almost half of adults were living with HIV. What's striking is this continues into middle and older ages. About a third of people in their 50s, 15 to 20% in their 60s, 5 to 10% in their 70s were living with HIV. And the recency of the rollout of medication suggests that the rates among older adults, so people who were born during apartheid, reflect new infection and not just survival. But it wasn't just HIV that was high in our study site. We found through biometric testing that most people in our study site, 73%, were living with at least one major health condition. 60% were living with hypertension, 22% living with HIV, 4% living with diabetes. And our interviews also revealed that participants lived with chronic pain, which was not measured in the survey. And strikingly, there's no significant trend by age group in the proportions having any disease. You usually expect disease to increase as people age, but that's not the case here. Everybody, or most people, are sick, and it's only the specific kind of illness that varied. So the interviews highlight the experiences of living in a syndemic zone. So 62-year-old Hezekiah, for example, these are all pseudonyms, who was in a wheelchair due to a disability, said, "My health doesn't have a station. I have sugar, diabetes, and high blood pressure. These things are troubling a lot. Sometimes you have pains, even if you've taken your medication. Sometimes it goes down. It's changing. Doesn't have a station where you can say, today you're all right." 50-year-old Sifiwe was living with HIV and on antiretroviral medication, described the illnesses among her friends and relatives. One of them is not feeling well. She's unable to walk. Then I push her with a wheelbarrow to go to the toilet. Yesterday, I was there helping her. Like now, if she calls saying she didn't sleep very well, she's very sick and hungry and very weak, I'll cook my food and give to her. When I arrive there, I bring warm water and give her to bathe and give her food after bathing. We just thought that if we can live in this way, things will go well. They're HIV negative. Their problems are sugar, diabetes, and high blood pressure. The interviewer responds, each has her own illness. And so this is life in a syndemic zone. So let me offer some concluding thoughts. So I've tried to argue that death is not randomly distributed across space, and that instead disparate health crises are built into and institutionalized in space through sociospatial containment in ways that create syndemic zones. In the brief case study, I sought to place these disparate disease outcomes in historical context in order to understand why particular places struggle with syndemics today. So in thinking about the future of public health, my work highlights the limits of attending to singular diseases, singular epidemics, and targeting only individual health practices. Instead, the focus should be on dismantling syndemic zones through revamping the policies that create them, the institutions in which such policies are embedded, and improve the specific places in which ill individuals live. This will enable policymakers to effect maximal change and, importantly, stem the intergenerational reproduction of health inequality. If we can design ways of death, then we can design ways of life. So I just want to thank people of Agincourt, the National Institute on Aging, Wellcome Trust, SAPRIN, Hewlett Foundation for funding, and OPR staff and OPA staff for administration, and of course the project team. So thanks so much for your
attention. So my talk today is going to be on reconsidering vulnerability. Specifically, I'll talk mostly about COVID, but it really applies to infectious diseases in general, especially respiratory diseases. And many examples will be from the US, but not all, because I think many of these principles apply elsewhere. So the question I'll address is, who is most vulnerable to COVID? And what have we learned through the pandemic? Okay. So a very early result, actually, from one of my former students, Jen Dowd, was pointing to age. And for those who are not demographers, there may be a few of you here, what this shows is that if you had two countries, in this case Brazil and Nigeria, which are roughly of equal population size, and you look at the left, you can see they have very different age structures. Okay, so Nigeria, if you follow this pyramid, has a very young age structure. It's broadest at the bottom, a lot of children, young adults, typical of many low-income countries. If you contrast it with Brazil, it has much more of a medium to high income country age distribution, bulging in the middle age, rather than at the young. And if COVID came along with a fixed set of age-specific death rates, you would see vastly different numbers of deaths between the two countries. Okay, Nigeria in red would have far fewer deaths than Brazil in blue, despite the same risk of dying at every age, because in fact, Brazil has a much older population, and the people most likely to die from COVID, to get infected, to be hospitalized, and to die are older people. And in fact, it's a graph like this that's often used as one of the possible explanations for why Africa has succumbed less to COVID mortality than rich countries in the West. It may or may not be part of the answer. Okay, if we look at what the media was showing us during the early days of the pandemic, here's an article that points to the importance of race, ethnicity, age, and sex, probably the four characteristics that got the most attention in terms of the risk of dying from COVID. Also, here's a graph that shows you, actually from my work, how the risk of dying from COVID goes up drastically with age, even more so in 2020 than 21, when vaccination started to play a role. Many other articles pointed to racial and ethnic differences, the high toll for the Black and Latino populations, which was huge both in 2020 and 21, and the most severe toll, which I've done a considerable amount of work on, for Native Americans that lost, as we'll see shortly, over 6 years of life expectancy in very little time. Okay. The other risk factor that got considerable attention from the media was the notion of comorbidities. People who had lots of chronic illnesses, diabetes, heart disease, liver disease, cancer, were also more likely to have a serious case of COVID and to die from COVID. So here's something from PAHO about the importance of underlying conditions, the importance of diabetes, increasing risk of dying from COVID, and again, another paper that talks about how people who have these chronic health conditions are more likely to develop serious COVID and to die from COVID. Okay. And just to show that I do read something beside the New York Times, here are a few pieces from The Economist pointing to very much the same kinds of issues. people's age alone, you would expect to see the disease to be 10 times more deadly in Italy than Uganda. That goes back to that first graph we saw of Nigeria and Brazil, pointing to the huge toll for Hispanic Americans, something they said they still don't understand why. That's been a big piece of my work, trying to understand why. And here, the economists actually developed a risk model where you could put in age and sex and comorbidities and actually have them spit back at you what the risk of dying from COVID would be. Okay, so all of that suggests that those groups that had highest disease rates and death rates prior to the pandemic from all sorts of causes other than COVID would in fact experience the largest death toll from COVID, right? And what I want to emphasize is that was true in part, but not entirely the case. Okay, so here's the part that's true. This is life expectancy, the number of years people could expect to live based on death rates in a given year. For 2020, from 2019 on top, 2020, then 2021, for non-Hispanic whites, non-Hispanic blacks, and non-Hispanic Native Americans. What you can see, first of all, is that there are huge differentials just in the height of this graph, very big differences in life expectancy across groups. And you can see that, COVID took a huge toll. The loss in those 2 years was 2.4 years for whites. It came out a little funny here. It was about 3-something years for the black population and over 6 years for Native Americans. So that's a huge, huge drop to experience in 2 years. The New York Times wrote all sorts of papers about a 0.1 year drop prior to the pandemic that was associated with partly with deaths of despair. So we're talking about something 25 times as big. Okay. But there are important exceptions. I've shown you the bits of the story that are consistent with having high rates of disease prior to COVID. And here I'll show you some of the exceptions. And now I've changed the scale a bit. The last graph started at 60 and went to 80. Now I'm starting at 70 and going to 90, so that the white population sits closer to the bottom rather than the top of that graph. It's the same numbers, just placed in relatively differently. So the white population here you see lost 2.4 years. The Hispanic population, which you can see, and that's a surprise to many people, had a 3 or higher life expectancy than whites prior to the pandemic. That's something known as the Hispanic paradox or the Latino paradox or the Hispanic mortality advantage, trying to understand why, despite lower income and lower education and poor access to health care, Hispanics live longer, but that's the story for another day. And Asian Americans who had a 7-year advantage over whites in life expectancy. So one would have thought, and I actually thought, that some of that advantage would translate into a lower impact from COVID, because it meant they had lower disease rates overall in order to be living longer, right? And what you can see is that definitely was not the case for Hispanics, who, other than Native Americans, suffered the greatest loss despite having lower death rates from many causes, not diabetes, and Asians, who in the first year of the pandemic actually had a greater loss than whites. And then in the second year, did not have an additional loss, unlike whites. Okay, so the question is, so what's the answer to this? Why did both Hispanics and Asians suffer huge losses, at least Asians initially, and what do they have in common? What they have in common is that a large proportion are immigrants. Okay, for Hispanics, it's roughly today about a third. For Asians, it's more than half. And as a consequence, in large part of large proportions of immigrants, is both groups suffered language difficulties, which made communication during the pandemic harder to do, harder to access reliable information, much more likely to live in crowded households and multi-generational households that facilitated transmission, much more precarious employment, much more likely to lose the job, not to have a high-level job with benefits, much more likely to be frontline workers in the sense that they couldn't work from home, as most of us did, and much more likely to lack health insurance and not to be able to receive the government subsidies that were available during the pandemic. All of these factors are much more prevalent among immigrants than natives, and especially undocumented immigrants. Okay. Something that's gotten very little attention, in part because the data practically don't exist, is how does the impact of COVID differ by nativity? These are data from Minnesota that probably had nativity information on the death certificate, which most places don't have, and hence it makes it hard to look at. And what you can see is, at least in Minnesota, in the first year of the pandemic, the foreign-born had higher death rates. It's the length of this bar adding up across these age groups than the native-born within every racial ethnic group. The foreign-born were more likely to die, which is, again, surprising because like Hispanics, which I use the word interchangeably with Latinos, there had been a foreign-born advantage in the length of life prior to the pandemic in the United States, quite a huge one. And this shows you data from France with the same story. So if we just look at men, the native-born were just set to a death rate of 1 arbitrarily for pre-pandemic 2016 to 19 and during the pandemic 2020. And then place of birth, people born, for example, in North Africa, had about 80% the mortality of people born in France prior to the pandemic, and then 5% higher during the first year of the pandemic. Even more so for people from sub-Saharan Africa, had 3/4 the death rate prior to the pandemic, then had 80% higher, right? So clearly, despite immigrant advantages prior to the pandemic in many Western countries, the pandemic took a greater toll on immigrants. Okay. A little bit of my work during the pandemic was to look at the kinds of occupations people had. And if you look at what proportion of workers by race ethnicity in the US were frontline workers, that is, it was very unlikely they could work remotely, you can see that very high proportions of men and women were frontline workers among Latinos, Filipinos, Vietnamese, all groups that suffered disproportionately from the pandemic, all groups that actually had higher life expectancy than whites prior to the pandemic. This is a brutal figure, and I don't have the time to go into it in detail. It's the simplest of them from this paper. But what it does is it tries to say the following: among frontline workers in each of these groups, what is the likelihood a person was specifically exposed to aspects of the occupation that were likely to promote infection? So they were like a healthcare worker, they had direct exposure to infection. They worked very close to other people. They had lots of face-to-face discussions with people. They had lots of interactions with external customers, or they were very likely to work indoors. The question was outdoors, but we just reversed it. And these orange bars, these orange-colored cells, show that not just being frontline workers, but these were particularly among frontline workers, these were people who were especially exposed to one of these 5 very directed risks of getting something infectious that was aerosol transmitted. And you can see, for example, here, Chinese, Filipinos, Vietnamese, Korean, other Asians were typically in orange rather than green, meaning less likely among the frontline workers. So these were people whose jobs put them in direct contact with other people or directly with the virus itself. And another way of looking at that, just little bits of data, was that if we look at Hispanics, they comprise 16% of all frontline workers in the US prior to the pandemic. That's roughly proportional to their population, but they were 40% of building cleaning service workers, a particular job that's low status and could not be done remotely and was not likely to have lots of protection in mind. If you look at foreign-born workers, they were 17% of all frontline workers, but almost 60% of maids and housekeeping cleaners, 41% of janitors and building cleaners, and 38%, just to give you a few examples, of nursing assistants, the kinds of jobs that were in those categories of high exposure to a virus. Okay, so these are all low status paying jobs with little protection and few mitigation strategies. Okay, so here are the kinds of lessons that we learned about mitigation for COVID or for aerosol transmission at jobs. There were many. You could protect yourself with masks, ventilation, physical barriers, social distancing. The workplace could do things specifically too. They could have occupational safety training. They could allow sick leave. They could test before people came back. They could enforce policies rather than make recommendations, something OSHA would have liked to have done but didn't have the resources to do. The point I want to make, and then show you the last slide, is that when we look at the types of jobs these different racial ethnic groups had, it's the high SES workers who are much more likely to have been able to do themselves or have had employers implement these kinds of strategies. They were not, by and large, implemented for low status workers, the kinds of jobs I showed you that were likely among immigrants and Hispanics. and certainly not in the informal or gig economy that many undocumented would be in. So would this improve in the future? I think we know much more about what we can do. Would it reduce inequalities? I'm very dubious that we would manage to do that. So let me end with a slide that comes from a student who's here, Jordan Klein. He sent me this slide. It's not from his data, but it's related to his thesis, which looks at the question of what are the social gradients in health for a disease like COVID? In other words, what are the differences in death rates by social status, by education, by income? And if for a number of diseases, COVID being one, if we looked at the very early days of the disease, in fact, surprisingly, high SES people were more likely to die. And that goes counter to what we see for most diseases. Why? Well, they were more likely to be travelers. They were more likely to be exposed directly or indirectly to people who had been in Wuhan. They were more likely to ski in Europe during winter break, and they were exposed to the European countries that got COVID first, et cetera. So that's the differential we see here with this dotted high SES line, higher than the two other black lines for low and medium SES. You wait a couple of months, and the gradient reverses itself. And we're back to the kinds of gradient we see across most diseases because of all the things we've talked about. The differential exposure that one has by SES, the different history of chronic diseases, and the other factors. And with that, I say thank you.
The estimated 10 to the power 33 viruses that make up the virome are arguably the planet's most successful self-replicating entity. Every progeny virus has approximately one mutation, and an infected human can carry 10 to the power 12 virions. Since for some of these viruses, their preferred substrate for replication is us, and since they're exploring all of the evolutionary space, it's clear that we have quite a challenge in our hands. My favorite description of a virus comes from Medawar, who called a virus a piece of bad news wrapped in a protein. And you will remember that in 2020, the news was very bad indeed. Many people worked incredibly hard to learn vast amounts about the virus very rapidly, from how and who it was killing to how it was spreading. And people from all around the world, from all career stages, set themselves an incredible pace, and we knew a lot rather early. But now that the dust is beginning to settle, we can start wondering, what might the next pandemic look like? What are the characteristics of what WHO and other entities have referred to as pathogen X? And so the first thing to note is that in all fiction, in every pandemic movie, like Contagion, Outbreak, The Last of Us, you always start with a pathogen that is almost everywhere and that can kill almost anyone. And there's a hidden assumption in there, and the assumption is that this pathogen can spread asymptomatically, or at least people who are infected may not initially, or maybe at all, show signs of the disease. And this could be a group of individuals who just don't develop sickness but can spread the disease, or the more nuanced way this usually plays out is that you're differentially ill at different phases of the infection. You get infected, at first you're not sick, then you start showing symptoms. And this feature allows viruses, pathogens in general, not just viruses, to travel long ways, to get around the globe, to put us in that scenario. The one that is most common is that we become sick, and then we might carry the virus for a little while, and then one starts transmitting. The degree of overlap between being asymptomatic and transmitting is really crucial for the degree to which we can actually control these sorts of viruses. If an infection can spread invisibly, then we're in a really bad place for trying to stop it. In 2002, in November 2002, SARS-CoV-1 spread out of China and moved across the globe. There were probably more than 8,000 cases and around 800 deaths. And stopping SARS-CoV-1 was a monumental achievement. And people like Carlo Urbani, a doctor whose name you might not know, but is someone who made 2003 a much better place on this planet and died in the course of this effort, put in warnings, alerts, managed to drive, everything from border checking to quarantining hospitals, and we managed to slow the spread of this infection. It would have been impossible to slow it, however. It wasn't easy, but it was possible because people who were transmitting this infection generally showed symptoms. And thus, we could identify them. Thus, we could know to provide care in particular careful ways, and we had just a much greater ability to prevent the spread. We weren't in the situation for SARS-CoV-2 where if you found it anywhere, you knew it was probably everywhere because it could spread invisibly. When this pandemic started, people were quite surprised that asymptomatic infection was a thing, but it's a very common thing, as probably many of you in the room know. A third of the world, perhaps less than that now, is infected with TB, and many of those infections are asymptomatic. We've all been on an airplane with someone with TB, for sure. The difference between being asymptomatic and not has probably made the difference between the enormous challenge of trying to eliminate polio, a current global task, because many polio infections are asymptomatic. This is by contrast with smallpox, where if you were transmitting the infection, you were generally covered in spots and very detectable. And this gave us a fighting chance of being able to contain this infection. Polio is just much more difficult. Right now, I'm standing in front of you. I probably have a couple of herpes viruses going on, maybe an asymptomatic adenovirus. We're all of us embedded in an ecology which we understand too little. So I think it's something that, getting a better understanding of that part of the landscape is crucial, but we also can deduce that this probably the thing that creates an existential risk will be something that can transmit asymptomatically. So asymptomatic spread is one of the characteristics we can look for. Noreen spoke about this eloquently and in much more detail than I will, but of course another important aspect of what creates a pandemic virus of existential risk is how the burden of disease plays out. Sanyu also touched on this. So this is a pattern of hospitalization of SARS-CoV-2, showing the very similar result where you have much higher burden at much later ages. There's also quite subtle differences that play out across sex. This obviously was hugely disruptive. Sanyu gave a wonderful talk I saw once where she referred to the real challenge of the ways in which it broke intimacy. People couldn't talk to each other anymore, and the huge societal burden that put on us all. Of course, one can imagine that a different pattern over age would lead to different sorts of challenges. The 1918 influenza pandemic famously, and for reasons rooted in the immunological history, really affected young adults. And it's not hard to see how that might be societally disruptive. There is also an echo there in the burden imposed by HIV. One could also imagine, and this was true of the 1918 influenza, that you could have a pandemic that preferentially targeted children, where children were really dying. I have a colleague who has suggested that actually SARS-CoV-2 is the perfect wicked problem because it killed enough older individuals to overburden health systems, but at the same time, enough people were asymptomatic that it was possible to not care. So we didn't make the vast efforts that we might have done if suddenly children had started dying in huge swathes. That might have created the sort of, overcome the inertia and created the ability to stop it. I don't know. A final way in which the burden can manifest, and this is something that happened during the Zika virus pandemic, is in creating congenital outcomes. So if women are infected during pregnancy with Zika virus, the child can be born with microcephaly. This is not an uncommon feature of known viruses or, in fact, of pathogens across the contemporary landscape. So these are called the torch pathogens. It includes toxoplasmosis, rubella. There's a couple out there. Is this likely to pose a societal risk? I think the ones that we know of tend to be extremely acute, and it should be possible, once you know what's going on, to protect people who might be at risk. However, it's not, everything seems to exist in biology, so one can also imagine one where the results of infection are chronic, whether the disease itself persists or whether the impact of it persists longer on. And that is clearly a societal and existential risk. COVID, of course, we all know is now associated. There are many patients affected with what is known as long COVID, And if that were more widespread, if the sequelae of infections were widespread, that is a clear, huge societal challenge. So the characteristics of pathogen X, we definitely know it has to have asymptomatic spread. We can imagine different scenarios for the nature of the burden. But there's one more really important piece for thinking about how a new pathogen might intersect with human populations. And that is in thinking about what happens after that first wave of infection. Somebody arrives who's infected, there's huge within population spread. Classically, this results in a vast wave of infection where just about everybody is infected. But what happens next? Are the people who were infected then immunized and thus never vulnerable to reinfection? That's the case for infections like measles. And then obviously you're just in a much better place there because your population is protected. Your vulnerable population then becomes new children being born. It's possible, this is more the case for SARS-CoV-2, that you are not protected from reinfection, but you might be protected from disease, or at least to some degree protected from disease. This is a really important distinction and also shapes the ways in which we would grapple with an emergent pathogen. The appearance of a vaccine in late 2020 was, of course, a miracle and a wonder. The consequences of vaccination are also going to be an important part of this landscape. The dream scenario would have been a vaccine that was completely immunizing, that prevented reinfection. That was not what we got, but the vaccines clearly, and all vaccine trials are geared toward this, prevent disease. I think there's an argument to be made we should be understanding the footprints of vaccination on transmission as well, but it's a hard problem. This is what happened. This is the world we're in. You can imagine a much darker world if you think about a virus like dengue. So dengue is a virus where the first infection with the first strain is bad, but if you get a second strain, it's really bad. So you get dengue hemorrhagic fever. And this is an issue, this was a global issue as you introduce one strain of dengue into a country, it's bad. Once the second strain turns up, you're in potentially catastrophic area where people have to be hospitalized when they get their second infection. So you can imagine that the challenge of that in managing the second wave of a pandemic would just be unthinkably difficult. So asymptomatic spread, the nature of the burden, immunity, I'm really focusing obviously on the biological dimension because that is my expertise, but all of this intersects with all of the social dimensions that Sanyu and Noreen and Angela in the context of regulation has brought up. I think that there's a lot we can learn on the biological side just from infections that circulate today. Many of these features I've talked about, there's nothing new under the sun in some ways, but there's an awful lot we don't know. And so, for example, we know if by looking at Middle Eastern respiratory syndrome, this is a coronavirus that comes out of camels and that people, there's an outbreak in 2014 right before the Hajj, and people in my public health community were losing their minds because they thought this was going to be it. But it turned out it wasn't it, and partly it wasn't it because the overlap between symptoms and transmission in MERS is extraordinarily tight. MERS seems to evolve really slowly. It's possibly something to do with the immune kinetics, which we're beginning to get a handle of. The way in which SARS-CoV-2 kills us is actually what it does to our immune system. People are dying long after the infection is cleared, generally. The post-acute sequelae are often rooted in immune system dysfunction. So I think we need to learn a lot more. We have the opportunity to learn a lot more. This is not something that's unique to COVID. Other infections do this. There's very big questions like, why are mucosal infections like COVID? We thought maybe we could develop an immunizing vaccine. Turns out we couldn't. If you look at the landscape of infections that affect our mucosa, it seems like it's extraordinarily hard to develop such a vaccine. And that might just be because it's an intractable problem for our immune system to grapple with. There's always stuff coming in and out. We're thinking about that too. And for flu, but also for the coronaviruses, there's now this question of can we educate our immune systems in ways that protects them very broadly? It's a burning question. All of these, I think, are rooted, many of the really interesting questions are rooted around the ways in which the immune systems function. And I think that one of the things I'd love to see in the future would be a global immunological observatory. It's obviously important that we go looking for viruses. It's obviously important that we do pathogen surveillance. But I think the thing that sort of grounds this all together is whether you or I, any of us, the degree to which we are or aren't immune. If we were to just sample everyone in this room, some of us would have infections, but that would be vanishingly rare. However, all of us contain signatures in our blood of all the pathogens we'd seen before. So there's a window into the past as well as a perspective onto what we are and aren't protected from in the future, because that defines immunity. So by looking just at the pathogens that are circulating, we're ignoring most of the iceberg, which is everybody else. And there are huge numbers. You know, we collect blood for HIV testing, we collect blood for malaria testing. There's huge samples all over the world collected all the time that are just sort of, you know, sometimes stored in freezers, sometimes just thrown away. There's a real opportunity to discover what this landscape of immunity looks like within our populations. And we also have techniques now where I could take a drop of your blood, which would be super creepy, but I could do it, and I could find out whether you had the signature of only 200 viruses are known to infect humans. So I could see which ones you'd seen, which one your immune system recognized, which would be astonishing, right? We put forward this idea during the pandemic, and there was some enthusiasm in various parts. And people always ask me, so where is it now? And it doesn't exist as is, but there are many flowers are blooming, and we have collaborators both around the world, at the NIH, in France at the Institut Pasteur, and various academic institutions who are beginning to lay the sort of find the proof of principle. So develop the power analyses to see how much you would need to know to show the ways in which we can better understand some of the endemic viruses, and think about how this might contribute. And these are just some of the papers and of some of the we had just a really remarkable lab group here at Princeton during the pandemic who worked unbelievably hard. So Benny Rice, Rachel Baker, and Shelley Sadroy are just three among many. And I do all of this with Brian. Thank you.
Can I ask a question? Yes, please do.
I was totally fascinated by your talk. When you do the Global Immunological Observatory, are you looking at antibodies? Is that how you're detecting that's just really...
So antibodies are the classic way right now.
Yeah.
And there are phage display techniques to biochemists that where one could sort of do a multiplex approach and get the antibodies to everything. I think there are also the question is, what else should we be measuring? How much of cellular immunity should we be understanding? It's sort of a case of build it and they will come, right? I think that the more data we have, the better we can tease apart what's going on.
It's first for the demographers, but also potentially has impacts for the regulation and for this idea of a global level immunological observatory. Is the role of National Health Service, does that have any impact on the sort of social, spatial containment that we heard about, or on these outcomes? I'm just wondering if nationally, you compared between, Noreen compared between the US and France. I'm just wondering if National Health Service, both in kind of regulatory issues, but also potentially in creating something across the board, is an issue, but also whether it impacts the differential impacts of health based on the syndemics and the social spatial.
Yeah. So thanks for that question. So ironically, I'd probably say no, or at least to a small degree, because I think a lot of the U.S. national debate is around access to healthcare, but in a sense, it's kind of all over by the time you're going to hospital. So education policy is health policy. Labor policy is health policy. Transportation policy is road policy, is health policy. So ironically, it's more kind of mandating every government agency to have one person whose job it is to say, how does this affect life expectancy? This policy. Well, if we're building a road in this neighborhood, how many people are going to die? How many babies? Some of Janet Curry's work showing, how, living next to a road with tolls. If it's pay toll, that more babies are going to die, right? So I mean, that the decision to take away pay toll was a life expectancy policy, health policy. So that probably did more than the hospital trying to save the lives of preemies, right? And so, in terms of, so ironically, the hospital is probably not where I would start. start, but I think having some sort of national policies around making sure every agency is thinking about health and life expectancy is where I would start.
Can I say one thing? So, I mean, there are very few reasons to be proud of being British these days. But one of them is the recovery trial, which developed many of the core drugs that were used to treat COVID-19, and that was possible because there was national health service. I don't think that would have been logistically possible without it.
So I have so many questions, actually. I think in a way we're all stunned by what you've shared, and also trying to think about a conversation across the four of you is also challenging. But I guess I want to ask, I want to make an observation and then pose a general question. Oftentimes when we think about addressing poverty and inequality, it sounds like we're talking about something totally different. But there's a recognition from the work by Amartya Sen that the ability to mobilize is oftentimes easiest when there are crises moments, where there's a particular moment and then people can mobilize around it, as opposed to deep and enduring issues of poverty and inequality, where you might recognize it, but you're either numbed to it or you have vested interest in keeping it the same way. And in a way, the first thing I'm kind of struck by in this conversation is how, obviously, not only how complicated it is, but responding to COVID or responding to SARS might be very different than responding to heart disease and diabetes and other kinds of things. But the second thing that Sen would highlight is that the ability to mobilize is really going to vary between democracies and authoritarianism as well. And so the examples you've just given right now were of democratic regimes with varying kinds of public health systems. But I'm wondering, in your own work, how you think about democratic versus authoritarian responses in the context of your own, and I can spin it in two different ways. One is that democracies, according to Sen, should be able to aggregate interests in a way where the politicians and bureaucrats have to respond, but it also can be much slower than some would say an authoritarian regime, which might be able to mobilize a response very quickly. So I guess I just want to ask those two questions in your work, how you think about crisis moments versus deep and enduring diseases, and secondly, the response of democratic versus authoritarian regimes. Noreen, looks like you want to jump in.
Boy, that's a tough question. I think there's so much variability across countries within a given type of regime. I think of, authoritarian China, of suppressing truth, suppressing information. There was the ability to act, and of course there would have been the ability to act quickly and have a huge impact. But the embarrassment, the shame, or whatever of starting an epidemic was forceful. And I think of the democracies. I think of the variability between, for example, New Zealand. My spouse is a New Zealander, so I'm always thinking about New Zealand. And many relatives were quite frustrated they couldn't move for months and months on end, right? Although there was a lot of support during the time. And then I think of the huge politicization of health in this country. There was an opportunity to mobilize. I'm quite sure that most of our social disparities, at least I know our racial ethnic disparities, increased between 2019 and today. And I don't see an easy remedy for that in this country. But there were other countries for which behavior was pretty much uniform across class and race and ethnicity. Yeah.
Well, I guess I'm sorry. One thing I might say is that when you think about risks from chemicals, and I'm certainly not trying to suggest that every chemical on the face of the earth is dangerous. It's not at all like that. It's just trying to differentiate the dangers of substances from, others is really difficult scientifically, and then we have very poor policies for implementing that. But one of the things I learned in doing this residues project with 6 other scholars, sociologists, historians, STS scholars, is we tend to think that the real risks are new. So for instance, COVID obviously grabbed the imagination. HIV/AIDS at the time grabbed the imagination. When we think about new chemicals, we get really nervous. And yet so many of the chemical hazards are old and known and were never dealt with. it's not as if the fact that we've had chemicals regulation for more than half a century means that the old problems are sorted out. There's still a lot of toxicity due to lead. Think about Flint, Michigan, or mercury. PCBs, which were banned in the 70s, are in everybody's bodies. I mean, old substances, both because they persist, but also asbestos. We never banned asbestos, and we know that the mortality rate that's associated with continuing to use asbestos. But it's much easier in a democracy that relies on risk assessment to quantify in dollar terms the cost of not using substance, a certain chemical, than it is to quantify the health benefits. So I also think that our regulatory tools tend to be pro-use, and we also tend to say we're not going to ban something unless there's an overwhelming amount of information that shows it's dangerous, as opposed to saying we're going to treat something as dangerous until shown safe. So I think even within a democracy, there are regulatory parameters that make it very difficult to address known hazards.
I'm trying to get my handle over your, so the gist of it is that there's 200 viruses extant, and we can get our handle around, get our hands around them. I'm just unsure as to what, where you're coming from. Because I grew up around a couple medical virologists and a clinical director at Merck, and I would hear these discussions all the time, and you're just not going to get your hands around viruses. They morph, and it's like a cancer. It's just...
Yeah, so I said two things. One of which is that there are possibly 10 to the power 33 viruses, and the other is that 200 some have been known to infect humans. It's probably a bigger number. But I do think one of the reasons that a program of just going out looking for viruses is not likely to be very successful is there's just so many of them, and most of them are irrelevant to us. And that's one of the other reasons to start looking at immunity, perhaps. I think in response to what Angela was saying as well, probably the best way to prepare for a pandemic is to strengthen routine services, right? Like to put slack in the system of hospitals, to build up surveillance. But no one's ever excited about that. Yeah. But that fundamentally, even the crises don't help us do the routine things, although they would probably be the best way to respond to crises.
Yeah, and just along with that as well, I'm not sure that the best policy is crafted during crisis.
Yes.
So in some ways, it's the aftermath of the crisis when you want the cooler heads and the benefit of hindsight and the sort of quieter, depoliticized bureaucratic process of changing systems, policies, and improving routine services. So, for example, it was clear, I think is becoming clear that a lot of kids' routine services were not as good during the pandemic, right? And what was interesting in some of our South Africa work, we did a longitudinal study and found that, in fact, a lot of the children's deaths in South Africa were not actually AIDS deaths during the height of the AIDS epidemic. There were deaths from other kinds of diseases. And so this was shocking because we had thought all along a lot of kids were dying of AIDS, which they did, but way more kids were dying, or more kids were dying of other diseases. So that made me think, gosh, this is so the bigger question, how to make sure during pandemics you're not forgetting routine things like immunization. And so it's, I think, post-crisis that is the most important. And crisis is probably not the time to make deep politicized, emotionally heightened moments are probably not the best time for policy making. That's my sense.
Off, this has been an incredibly difficult set of observations that you've shared with us. On that note, challenging to walk out and to think about the policy solutions. I think the word you used, Noreen, was doubtful in terms of moving forward, but also how salient and important. So the first is thank you for helping us to think about that. But second, thank you for sharing your brilliant scholarship with us. It really has given us a handle on not only the work that you're doing, but an effort to think about really the multidisciplinary conversations that have to be promoted for us inform not just the disease on its own term or health on its own terms, but the policy and economic and historical conditions that can help give rise to hopefully a better outcome. So thank you so much.
Thank you.